Hello, and first of all, thanks to the organizers of this COMy event for inviting me once more again to this important event this year conducted in a virtual way. And I have to discuss about the management of the elderly myeloma patients, and I have to defend the utilization of proteasome inhibitors-based therapy for this population. You can see here my disclosures. And when we evaluate the treatment of patients with multiple myeloma over the years, it's important to recognize that melphalan and prednisone was the standard of care for more than 40 years for this population. However, if we focus on the last century, it's true that the proteasome inhibition was one of the most relevant steps to improve the survival of elderly patients with newly diagnosed multiple myeloma. We've learned that the proteasome ubiquitin pathway was something relevant in multiple myeloma because this is a disease in which high amounts of proteins are secreted in serum, and as a consequence, there is an accumulation of misfolded or unfolded proteins into the endoplasmic reticulum, resulting into a stress responsible of the activation of a way for the degradation of all these proteins. And we've learned also how the proteasome was something relevant. And in the right part of the slide, you can see the structure of the proteasome that we learned also when the proteasome inhibition arrived to the management of our patients with multiple myeloma. The inhibition of proteasome action by proteasome inhibitors treatment is something relevant in myeloma because this inhibition is going to result into the accumulation of misfolded proteins, resulting into apoptosis and cell death due to DNA damage. But in addition, we know that the proteasome inhibitors also inhibits the myeloma cell interaction with stroma cells. And we know that this fact is going to finally to result into an inhibition of the myeloma cells proliferation. So in summary, I think that while the myeloma cells have a higher level of proteasome activity when compared with normal cells, in fact, we know that there is a greater sensitivity to pro-apoptotic effects from proteasome inhibition given their increased production and secretion of proteins. And definitely we know right now in 2021 how the proteasome was considered as a therapeutic target in myeloma, and its inhibition is a cornerstone of myeloma treatment. Which proteasome inhibitors do we have to be utilized in the management of patients with myeloma, and specifically the elderly population? The first one is Bortezomib. Bortezomib is a reversible boronate proteasome inhibitor that can be delivered as IV or sub-Q administration. And we know that Bortezomib was evaluated in preclinical studies in combination with the standard of care for the elderly population, melphalan and prednisone. And this is a preclinical study conducted in myeloma cell lines showing how Bortezomib was synergistic when it was combined with melphalan and dexamethasone. And in fact, this preclinical study was the rationale for the combination in vivo in patients with multiple myeloma. And the final result was the VISTA trial, conducted some years ago and published in 2008, but definitely the addition of the proteasome inhibitor Bortezomib to the standard of care melphalan and prednisone resulted into a significant benefit, not only in terms of time to progression, but also in terms of overall survival. VMP has been a classical standard of care commonly utilized for the management of elderly patients with multiple myeloma. Based on the VISTA study, the Bortezomib administration was optimized in the elderly population through two important ways. The first one, the weekly administration, because the weekly administration is going to result in similar efficacy but definitely in less toxicity, especially gastrointestinal toxicity and peripheral neuropathy. The second way to optimize the administration of bortezomib was the subcutaneous formulation. Bortezomib-based combinations we know that are also effective in the management of patients with high-risk cytogenetic abnormalities. And this is a retrospective study presented some years ago by Alessandra Roca at ASH, but in approximately 1,000 patients with a newly diagnosed myeloma, when they had or they presented with high-risk cytogenetic abnormalities, bortezomib resulted in a more effective approach for patients with high-risk cytogenetic abnormalities. And definitely the proteasome inhibitor-based combination VMP has been recently optimized by the addition of the monoclonal antibody anti-CD38 daratumumab. And this has been evaluated in the Alcyon study. The median follow-up for this study is now 40 months, and the addition of daratumumab resulted into a significant benefit in terms of progression-free survival, 36 months versus 19.3 months. And most importantly, this is the first study conducted with daratumumab in the upfront setting, showing significant benefit also in terms of overall survival. Important to note that in this study, VMP plus daratumumab were given during the first part of the treatment, during the first year, and patients received subsequently daratumumab monotherapy. And this is important because please keep in mind this graph, because we are going to see how potentially the proteasome inhibition will contribute to improve this progression-free survival curve. The addition of daratumumab to the VMP resulted into a significant benefit also in terms of overall response rate, 91%, and important to remark that approximately 50% of the patients achieved complete response, and minimal residual disease was also evaluated, and approximately 1 out of 3 patients receiving dara plus VMP achieved minimal residual disease negative. And we know, as we can see in the right part of the slide, this is an important surrogate marker predicting progression-free survival. The achievement of minimal residual disease at a specific time is important, but maybe today is much more relevant to maintain the negativity for the minimal residual disease status. And this has been also evaluated in this combination, VMP plus daratumumab, and approximately 15% of patients treated with this combination sustained the minimal residual disease negative at 1 year, and this translated into a significant benefit in terms of both progression-free survival and overall survival. The addition of the monoclonal antibody daratumumab to the proteasome inhibitor-based combination VMP did not result in more significant adverse events, and tolerability was quite good. This translated into the approval by both FDA and European Medicines Agency for this combination, VMP plus daratumumab, in the treatment of elderly patients with a newly diagnosed multiple myeloma. But it's true that the proteasome inhibitor bortezomib can be also added to immunomodulatory drugs. And in fact, bortezomib, lenalidomide, and dexamethasone is another combination already approved to be utilized in this population. The rationale has been the SWOG study, conducted in newly diagnosed myeloma patients in which transplant was not planned as part of the first line of therapy. And again, the addition of the proteasome inhibitor to lenalidomide and dexamethasone resulted into a benefit in terms of progression-free survival and overall survival. Important to note that a specific subanalysis was conducted in this study according to the chronological age, and the superiority of VRD over RD was sustained in patients older than 65 and also older than 75. If we consider that VRD, according to the SWOG study, can be mainly applicable to fit patients, it is possible to optimize this combination through the use of the RVD light scheme, basically based on the optimization of both bortezomib and lenalidomide. This study is based on a quite small sample size, only 50 patients, but I think that the results are applicable to the clinical practice to utilize this combination in newly diagnosed myeloma patients if they are not fit enough to receive the complete RVD according to the SWOG scheme. Definitely, it's also possible to optimize bortezomib, lenalidomide, and dexamethasone by the addition of monoclonal antibodies targeting CD38, and the combination RVD plus daratumumab is going on in a phase 3 randomized study. And the same for the combination based on RVD plus isatuximab, the another anti-CD38 monoclonal antibody. Concerning this latest combination, we have some preliminary data based on 27 newly diagnosed myeloma patients non-eligible for transplant, in which this combination resulted quite effective. And definitely there is also a phase 3 trial ongoing, and we have to wait to know the results of both phase 3 randomized studies. But in summary, I would say that concerning bortezomib as proteasome inhibitor, definitely has been one of the most common drugs used in the elderly population over the last 15 or 20 years. I would say that maybe the only contraindication for bortezomib would be the presence of a peripheral neuropathy. Bortezomib can be used in the different subgroup of patients like acute renal impairment, high-risk cytogenetic abnormalities, and definitely in 2020, bortezomib continues being a good partner for other drugs to generate optimal combinations for this population, like VMP plus daratumumab, VRD, or VRD plus anti-CD38 monoclonal antibodies. What about second-generation proteasome inhibitors for this population? Carfilzomib is an irreversible epoxy ketone proteasome inhibitor of IV administration. Unfortunately, the combination based on carfilzomib plus melphalan and prednisone was compared with the standard of care bortezomib, melphalan, and prednisone, and this study did not meet its primary endpoint, progression-free survival. And you can see here, like both combinations were almost identical in PFS and overall survival. We can potentially discuss the rationale. Dose of carfilzomib, melphalan maybe is not the ideal partner for carfilzomib. We don't know. What we know is that we have some phase 1-2 trials combining carfilzomib with either cyclophosphamide or lenalidomide and dexamethasone in this specific population, non-transplant eligible, newly diagnosed myeloma patients. The efficacy results are quite good, but definitely it's true that there is not any phase 3 randomized trial showing its superiority. Just to note that concerning the dose and scheme of carfilzomib, in the carfilzomib plus cyclophosphamide and dexamethasone trial, carfilzomib was utilized once per week, and I think that this is the optimal way to move forward with the use of carfilzomib in this specific population. This is one example. Professor Ludwig is conducting this phase 2 randomized trial in Austria, comparing carfilzomib, thalidomide, and dexamethasone with carfilzomib, lenalidomide, and dexamethasone in newly diagnosed myeloma patients non-transplant eligible. And you can see here, like carfilzomib from the cycle number 3 is utilized just once per week. Preliminary data were presented at ASH 2019, putting together data from both arms. And the important news from my point of view is how almost all patients responded to this combination, overall response rate 96%, with 30% of patients achieving complete response, and with progression-free survival and overall survival curves encouraging, although it's true that the sample size is reduced at the moment of presentation, 63 patients, as well as the follow-up. But definitely this trial put in context that it is possible to investigate in carfilzomib-based combination for non-eligible newly diagnosed myeloma patients. And in fact, this is the Spanish approach, also based on the evaluation of two carfilzomib-based combination, KRD or KRD data, in newly diagnosed myeloma patients but fit. And these two experimental arms will be compared with 9 cycles of VMP followed by Lendex. Carfilzomib is also used once per week since the cycle number 3, and the trial is going on, and we needed to wait in order to know the final results. But definitely carfilzomib is another proteasome inhibitor that can be utilized in this population, although it's true that today there is not any official approval for this drug in this population. The only contraindication for carfilzomib would be maybe the presence of a high cardiovascular risk or prior medical history, including severe cardiovascular diseases. And definitely in this population, the weekly administration is something crucial to maintain on treatment to the elderly population. The third proteasome inhibitor is Xavier, a reversible boronate proteasome inhibitor, but important to note, of oral administration. Xavier was first combined also with melphalan and prednisone and evaluated in this phase 1-2 trial. The median progression-free survival was of approximately 2 years, and you can see here the overall survival. And unfortunately, this trial did not move toward a phase 3 randomized study, and so this combination remained quite stopped, although it's true that ixazomib was combined with lenalidomide and dexamethasone, first in a small phase 1-2 trial with 65 patients. And although the results were quite positive, the phase 3 randomized trial comparing ixazomib, lenalidomide, and dexamethasone with lenalidomide and dexamethasone alone, well, this trial announced some months ago that this trial did not meet its primary endpoint for progression-free survival. Definitely, we have to know the final data in order to see if there is any specific subgroup of patients that could potentially benefit from this combination. And due to the convenience for the administration of ixazomib, maybe the frail population would be an ideal population to utilize this proteasome inhibitor, and the HOVON group is evaluating ixazomib in combination with the daratumumab in this population, frail and unfit patients. And again, although the number of patients is quite reduced, I think that the data are encouraging if we consider that the population were unfit and frail patients. And I would like to focus on the low early mortality rate reported in this study. Definitely, ixazomib plus lenalidomide and dexamethasone didn't meet the primary endpoint, although the final results are pending, and ixazomib tolerability and the oral administration make possible to consider it as an appropriate drug for the elderly population. Proteasome inhibitors, it's true that they have been usually utilized as part of the combinations of fixed duration. And my next approach in this part of my debate is to try to debate if is there any role for proteasome inhibitor as maintenance therapy. Bortezomib is feasible to be utilized as maintenance, and this was evaluated in 2005 by the Spanish myeloma group. And after VMP, patients received the maintenance with bortezomib plus either thalidomide or prednisone. Although it's true that in this study, both maintenance arms received the bortezomib, the complete response rate increased with maintenance up to 42%, and the median progression-free survival and overall survival improved in comparison with the classical VMP of fixed duration. And the Italian myeloma group showed the benefit of maintenance with bortezomib plus thalidomide in this randomized study because the control arm received the VMP with no maintenance, and the addition of maintenance with bortezomib plus thalidomide resulted into a significant benefit in both PFS and overall survival. And if you remember, I asked you to keep in mind the progression-free survival curve from the Alcyon study, because the Spanish myeloma group is going to try to optimize the progression-free survival curve from this study by the addition of bortezomib as maintenance. And this is an observational study, and this is what we will expect from this optimal approach. This is a simulated curve, but using bortezomib as maintenance, we expect to improve significantly the progression-free survival. Concerning ixazomib, if you remember, I showed you previously this slide, but I would like to focus right now on the fact that some patients continued receiving ixazomib as maintenance after induction with ixazomib plus melphalan and prednisone. And in this population, although small population, the progression-free survival was not 22, but almost 39 months. And this is important because we can potentially capture ixazomib as oral proteasome inhibitor to be utilized as maintenance therapy. And in fact, this is the Tourmaline MM4 study, in which ixazomib has been compared versus placebo in more than 700 newly diagnosed myeloma patients non-eligible for autologous stem cell transplantation. And results are pending to be presented in the next congresses, but a press release announced that this trial met its primary endpoint, progression-free survival. So this is an excellent news from my point of view, because this is an oral drug that can definitely be utilized as maintenance therapy in the transplant-ineligible newly diagnosed patients. In summary, I think that definitely there is a role for the use of proteasome inhibitor-based combinations for myeloma patients non-transplant eligible, because proteasome inhibitors are key elements in the treatment of patients with myeloma in general. There is not basically any contraindication for its use in this population, with the exceptions I previously said or mentioned during my presentation. And definitely due to the complexity of the disease, proteasome inhibitors alone or with steroids would be indicated for frail patients with renal impairment. Proteasome inhibitors have to take part of the different multi-drug combinations, and I think that proteasome inhibitors are excellent good partners to be combined with immunomodulatory drugs, monoclonal antibodies, or alkylators. And I stop here. Thank you very much for your attention.
Hi, my name is Vincent Rajkumar. I am a professor of medicine at the Mayo Clinic. And today's debate topic for me is treatment of smoldering myeloma. And my position is that we are ready for prime time. I have no significant conflicts of interest to disclose. Before we get to should we treat smoldering multiple myeloma, or is smoldering myeloma treatment ready for prime time, we have to step back and ask, why are we not treating smoldering myeloma? Smoldering multiple myeloma was described in the 1980s, and since then, we have always thought it's better to just watch and wait and not treat patients with smoldering multiple myeloma. And the three main reasons why we said let's not treat patients with smoldering myeloma was that all these years, the argument was we don't have good treatments. So any kind of treatment would not be very effective for patients. Number two was that we couldn't tell which patients with smoldering multiple myeloma would progress to multiple myeloma and which patients would just remain stable for many, many years. In other words, we didn't have good risk stratification. And most importantly, the third factor was we did not have randomized controlled trials that showed us that you could get clinical benefit with early therapy. So these are the three reasons why even though we recognize smoldering multiple myeloma has a high risk of progression to an incurable malignancy, 10% per year, we still did not recommend therapy. What I will show to you in the next 15 minutes is that none of the three reasons why we said observation is enough are true anymore. In the year 2020, we have good treatments, we have good risk stratification, and we have evidence of benefit with early therapy. So the treatment is definitely ready, in my opinion, for prime time. And I will go through with each of these. Number one, in the days when we said we should not treat smoldering multiple myeloma, all we had were old drugs, alkylators, steroids, anthracyclines. Since then, however, we've had many new drugs come up. The initial ones, Bortezomib and thalidomide, were not amenable to treatment of smoldering myeloma because they carried significant side effects. Since then, lenalidomide has shown to be a drug that you can use for maintenance therapy in myeloma for many, many years. And many other drugs have been approved since 2013, which have all shown high activity, and more importantly, many clinical trials are going on with these drugs in smoldering myeloma, many of these drugs. There are many, many more new drugs to come. So to say that we do not have any good treatments and therefore we should not treat smoldering myeloma is no longer valid when we have a wealth of options. Number two, the main reason we said we should not treat smoldering myeloma, we should just observe, is that we couldn't tell who was going to progress and who was not. If you look at this slide, you will see that unlike monoclonal gammopathy of undetermined significance, where the risk of progression is 1% per year and it's fixed throughout the course, in smoldering multiple myeloma, there are two differences. One is that the rate is much higher. It's 10% per year, not 1% per year. And number two, it is not fixed. After 5 years, the risk of progression slows down to 3% or 3.5% per year. And after 10 years, it slows down to more like 1% per year. This observation has really made us realize that smoldering multiple myeloma is not really an entity which is smoldering in between MGUS and multiple myeloma, but rather it is really a clinical entity, arbitrarily defined clinical entity, where if you have 100 patients with smoldering myeloma, half of them really biologically have MGUS, and half of them biologically have multiple myeloma, and we don't know who's who. So the fundamental paradigm shift is, rather than think of smoldering myeloma as a pre-malignancy that is sitting in between MGUS and smoldering, we now think of it as a heterogeneous clinical entity in which some patients have MGUS and some patients have myeloma. And if we knew who had myeloma, we could treat them and leave patients with MGUS alone. And this is very, very important as a principle to keep in mind as we move forward. We now have many biomarkers that tell us who has really the full-blown myeloma, even though we don't have symptoms, and who is really still in a pre-malignant MGUS stage. The first step was to identify the small number of patients who progress rather quickly. And so the International Myeloma Working Group decided to look for patients who had an 80% risk of progression within 2 years. We identified 3 biomarkers: 60% or more plasma cells, 100 or more light chain ratio, and more than 1 focal MRI lesions. These patients do not have a 10% per year risk of progression, but rather a 40% per year risk of progression. And the IMWG agreed that these patients should be called as myeloma and started on therapy. You would notice that this is a very small proportion of patients with smoldering myeloma, the green box. Now, when you fast forward to 2014, when we had all this information, the IMWG finally published the updated diagnostic criteria for myeloma, which automatically also updated the definition of smoldering multiple myeloma. So smoldering multiple myeloma is now defined as 10 to 60% plasma cells, more than 3 grams M spike, and no myeloma defining events. This is the group that we are focusing on. If you start therapy for the myeloma patients, then it's too late. If you start with the MGA stage, then it's too early. But the smoldering myeloma population is the group that we have to look at closely. And in this group, what we have to do is to separate the patients with high risk smoldering myeloma, the ones who have already had the malignant change, who in reality are myeloma, but they have not yet developed symptoms. And they have a 25% per year risk of progression. You have to separate them from patients with low risk smoldering myeloma, who have only a 5% per year risk of progression, who biologically more or less have MGUS. Now, we have many biomarkers now that tell us who are the patients with high risk smoldering myeloma. We published in 2015 a list of factors, including high M spike, absence of normal plasma cells, abnormal light chain ratio between 8 to 100, certain cytogenetic abnormalities like del17, 414, and gain1q, IgA smoldering myeloma, evolving pattern, increased circulating plasma cells. All of these are biomarkers. If you have multiple biomarkers, then it's even more likely that these patients are biologically myeloma and destined to progress quickly. More recently, we have a very simple approach called the 2220 risk stratification system. This was published by the Mayo Clinic in 2018 and makes life very easy. It looks at only 3 factors: bone marrow plasma cells more than 20%, M spike more than 2 grams, and free light chain ratio more than 20. If patients have any 2 or 3 of these factors, they have a risk of progression of approximately 50% within 2 years. That's not 10% per year, 25% per year, our previous criteria where we said this is the group that is high risk. This has since been validated by the International Myeloma Working Group in 2019, presented at ASCO, 1,151 patients. And you can see here that the high risk group with the 2220, with 2 to 3 risk factors, has almost a 50% risk of progression at 2 years. This is the group that we want to target. This is the group that is not going to be progression-free for many, many years, but is rather more likely to progress within the first 2 years. So I have showed you data that we have many drugs, so this is no longer an excuse. I've shown you data that we have good risk stratification that can identify the patients at high risk of progression within 2 years. No risk stratification is perfect, and we'll continue to improve on this. And now I'll show you data that we do have evidence that early therapy is of benefit. The first data for this comes from a randomized controlled trial conducted by the Spanish group, published by Marie V. Mateos, Dr. Mateos in 2013 in the New England Journal of Medicine. They looked at lenalidomide and dexamethasone versus observation. And you can see there is a marked difference in risk of progression between patients who got lenalidomide and dex versus those who were observed. These are patients with high risk smoldering myeloma, like the type I mentioned to you, with a 2-year 50% risk of progression. They had an 82% reduction in the risk of progression with just simple oral lenalidomide and dex. Not only was the progression-free survival improved, but the overall survival was also significantly improved with early therapy with lenalidomide and dexamethasone. This was a very important study, but people found that there might be some caveats. One was that the risk stratification system was not universally available. 2 was that we were using lenalidomide and dexamethasone. We weren't clear how much of the benefit was coming from the lenalidomide and how much was coming from the dexamethasone. Plus, we needed at least one more randomized trial to confirm this. And that is what we have now with the ECOG trial that was presented, that was published in the Journal of Clinical Oncology by my colleague, Dr. Sagar Lonial. Here we find that if you look at patients with smoldering myeloma treated with just lenalidomide alone versus observation, no dexamethasone, the progression to end organ damage, Again, this is different than progression-free survival used in myeloma studies. This progression to actually symptomatic end organ damage was significantly longer with lenalidomide therapy compared to observation. The study has very few patients who have died, only 6 patients, 2 in the lenalidomide arm and 4 in the control arm. So it's too early to comment on overall survival. In this study, we applied the 20-20 risk stratification, and that is the high risk group. And you can see that the benefit is really seen in the high risk group of smoldering myeloma, very consistent with the Spanish results. And in this group, the risk reduction is almost 90%. And that is the group that we are now recommending is ready for prime time for therapy. So in summary, the 3 reasons why we did not want to treat are no longer valid. We do have good treatments, we do have a good risk stratification system, and we do have evidence that early therapy is of benefit. And therefore, here is my algorithm for potential newly diagnosed patients with possible myeloma or smoldering myeloma. Clearly, if the patient has a myeloma defining event, we should treat those patients. If the patients have no myeloma defining events, then we try to find out if they have high risk smoldering myeloma or not. The best way to do this is with the 20-20 system. And if you have 2 or 3 risk factors, then they do have a high risk. If they have no high risk factors, clearly we just continue to observe them. If they have high risk smoldering multiple myeloma, we recommend therapy with lenalidomide or lenalidomide plus dexamethasone. Or better still, enroll them in clinical trials. But I don't think that this group should be observed without therapy. Now, people may ask, why lenalidomide or lendex? Why not we just use myeloma-like therapy? Well, that needs to be shown in a randomized controlled trial that such an approach is valid. And that kind of trial is currently ongoing in the US, where a preventive approach, like with just simple lenalidomide dex, is compared to a myeloma-like triplet with daratumumab lendex. This trial is accruing, and I urge you to wait for the results before making any preemptive conclusions. Now, much of this applies to patients with newly diagnosed smoldering myeloma, but when we see patients with smoldering myeloma in practice, as we follow them, we are going to find out that some patients have a rise in their monoclonal protein levels or the free light chain ratio. Then what do? We need to be aware that as we follow the patients, we're going to get more new information. And as new information occurs, even if you have previously said the patient should be just watched, if you find that the M spike is going up by 0.5 gram, and at the same time the hemoglobin is following by 0.5 gram, and the bone marrow plasma cells is more than 20%, those patients have a 90% risk of progression within 2 years. That is the people with 3 risk factors: bone marrow more than 20%, hemoglobin is fallen by 0.5 gram, M spike has gone up by 0.5 gram. So be prepared to follow these patients, and if the M spike is going up, then that's something that we have to be careful about. Another evolving sign is change in the MRI. If the MRI was normal and it became abnormal, or if the MRI showed less than 0 to 1 focal lesion, and now it's showing 2 or more focal lesions, then we should be prepared. Here is a study which shows that evolving MRI findings are associated, the red curve, with a high risk of progression. So not just a static recommendation, but even if we choose not to treat patients with smoldering myeloma, we should be prepared to treat once we see changes in M spike free light chain ratio or MRI. Now, the trial strategy for smoldering myeloma is very complex, but I would encourage all patients to continue to enroll on clinical trials. We certainly have to do trials for the regulatory purpose to prove each drug that we use for smoldering is really FDA approved and approved by the EMEA and other regulatory authorities. So in that sense, the necessary trials have been conducted. Daratumumab randomized trial has completed accrual. Lendex, Len trials have been done. These are necessary trials for regulatory reasons. Then we have the strategic trial. Can we delay progression better and improve outcomes better with the myeloma-like triplet? And as I mentioned, the ECOG trial is going on and others are going on as well. Finally, we are now starting to look at if early therapy delivered in a very effective way can actually even cure myeloma. And such trials are also Early results are available from CSER, and the ASCENT trial in the US is ongoing. And these are trials that are utilizing all of the treatment options we have early in high-risk patients to see if we can cure the disease. So I'll conclude by saying, so whatever reason we had for not treating patients with smoldering myeloma is no longer applicable. I do not recommend treatment for all patients with smoldering myeloma, but for the patients with high-risk smoldering myeloma as defined by the Mayo 2018, IMWG 2019, I do certainly think that it's time to treat and it is ready for prime time. Thank you very much.
So hi, everyone. I'm Professor Xavier from France, Poitiers. I'd like to thank the COMy organizers, particularly Professor Mohammad Moti, for inviting me to debate with Professor Vincent Rajkumar. It's a great honor to debate with Professor Rajkumar. It's also a very tough job because Professor Rajkumar has been one of the pioneers to anything we're going to talk about. I think I've been lucky enough to get this not yet treatment should be given to the patients with multiple myeloma we're going to speak about, and hopefully that will help me convince you in that debate. By the way, I'd like to say hi to Professor Rajkumar. Again, very honored to debate with him. And hopefully this discussion he and I will have will be interesting, informative, and fulfill the needs of the audience. So what we are going to talk about is indolent or smoldering multiple myeloma, whether or not we should treat these patients. And my topic, my job, is to defend the no, it's not yet time to treat these patients. I'd like to start saying that a while ago, I was in a debate. I was not very happy with the title of the debate, and I would say geniusly changed the title. Back then, my chairman, Professor Bowowlowski, told me that it was great that I changed the title because, for teaching purpose, potentially the title was not optimal, and maybe it could have been rephrased. So I wish, again, this time to change the title slightly. And I think what we are going to discuss is it time to treat patients in the real life? I participate to clinical trials in that population of patients with indolent multiple myeloma, and I'm very happy to participate to clinical trials. I do think we need to address the question of treatment in the context of clinical trials, but we should not, and I think you should keep in mind that for no reason you should treat any patients that you consider indolent with multiple myeloma. And maybe I should stop here. The debate is gone, it's done, but I certainly should, and I will give you a little bit more reason and my reason for why we should not treat in real life. So here are my disclosures just in case. I'd like to start with a case to kind of make everyone really understand what we talk about. So we are talking about a smoldering indolent multiple myeloma. So here is a 61-year-old male. The routine lab tests are depicted below, and I'm not going to go through that too much because I don't want to spend too much time. But overall, the patients had a systematic routine check lab, and this is how a number of abnormalities were found biologically. Just for you to know, it's a patient that is doing great. No prior history of any type. Clinically, the patient was doing great. CBC found an anemia. The characteristics of the anemia are listed here. The renal function and the calcium level, serum level were great, normal. Serum electrophoresis found an M spike above 30 grams per liter for Professor Rajkumar, above 3.0 grams per deciliter. The isotype, IgA lambda, by immunofixation. Nothing in the urine. Serum-free light chain is listed here for you with a ratio of 16, so largely abnormal, but below 100. And the involved light chain, lambda, which is 82, below 100 milligram per liter. The patient had a whole body CT scan. He was sent to me with that exam. It might not have been the exam I would have performed myself, but the patient was sent to me with that exam, and there was nothing relevant on this whole body CT. So what are we talking about here? This is typically a smoldering multiple myeloma that most of us we see in our consult. And I do believe there is absolutely no reason to treat that patient. And I do believe that none of us can predict when that patient will progress. So the question we're asking here is, do we have other exams we should perform? And why are we performing these other exams? I do believe the question that we ask here is how often I am going to see that patient in my consult, and how could I help the patient appreciate whether myeloma will develop within 1 year, 2 years, 5 years, or 10 years. So first point, do we have other exams we should perform? Well, yes, I do think you should perform a bone marrow aspiration in the US biopsy, not too much to confirm myeloma, because this patient has myeloma. The marrow will confirm something we already know. However, I do think that the genomic could be of some interest, and you will see throughout my talk why is that. You still have to look into whether the patient is CRAB, old and new criteria, and potentially if the bone marrow is involved beyond 60%, it's a new criteria for treatment. And therefore, that is a reason also why we should perform a marrow aspiration, because then you would treat the patient. But I can already tell you that the patient will likely having something between 10 and 30% involvement and not 60%. You should perform an MRI of the spine and the pelvis, because if you see multiple focal lesions more than 0.5 centimeter size, then you should consider the patient for treatment. And again, I can anticipate that that patient will have a normal MRI of the spine and the pelvis. Therefore, what we are talking here is not too much whether my patient should be treated and discuss how am I going to treat the patient, but how often I'm going to monitor that patient in consult and trying to help the patient anticipate when the life will change from a watch and wait period to a treatment period. Honestly, when is that patient going to progress? I do not think anyone on earth can answer that question. But is this patient high risk smoldering and therefore require maybe more than once a year visit and even more than twice a year visit, potentially 3 or 4 times visit, or if a patient is not visiting you and a lab test should be performed, I believe that is the case for that patient. So we should monitor that patient slightly more carefully, but I don't think here we should discuss much whether or not that patient requires treatment. Now, if a clinical trial proposing a treatment is available and look at how we could improve these patients by treating this patient earlier on to avoid myeloma defining events and organ dysfunction because of myeloma, then I would consider treating that patient. So I think this is really what we are talking about here, and I hope this case helped you put things into context. So what do we know about smoldering myeloma that I know possibly Professor Rajkumar would have duplicated that slide, and I hope the message here will be the same, because this is what we know. So we know that some patients have a pre-malignant stage called MGUS, and we know these MGUS down here in the green curve here, a circle, we know this patient requires no treatment. A number of them will develop myeloma, a number of them will not develop myeloma. And these patients clearly have no malignancy, not at the time of MGUS. We know the red circle, the very steep curve here on the upper curve, steep part of the curve on the upper curve. We know these patients have myeloma. This is one of the most important and greatest in development of the International Myeloma Working Group has done in the past 5-10 years, which was to stop treating patients when the CRAB criteria with organ malfunction and organ disruption was already available to patients, some of them having a severe bone lesion then because of that, or other having kidney malfunction because of that, but an international attempt to identify criteria to treat this patient earlier on, while they are asymptomatic, but still not indolent anymore with active myeloma. These are the SLIM criteria, which are listed down the table here. Clonal bone marrow plasma cell above 60%, greater or equal, serum filtration ratio involved over uninvolved greater or equal 100, and more than one focal lesion on MRI, things I've spoke about a minute ago. And it is obvious that these patients do require immediate treatment. You can discuss within your team if it's immediate or delayed, but these patients can be treated because we know most of them, 80% plus, will develop myeloma within 2 years. That has been published, that is validated, and that is not what we are talking about today in that debate. Now, in between the MGUS and MM, we have the SMM with the old global definition of what is smoldering. And then the question is that, should we stick there, not make any progress, or should we try to consider, which I'm going to show in a minute, is a case that SMM is an heterogeneous group, and if some patients might mimic MGUS, maybe some patients, the so-called high-risk smoldering, might mimic active myeloma, and then comes the discussion of whether or not we should treat these patients. So Professor Bob Kyle, long time ago, has shown very nicely that SMM is an heterogeneous group. All these patients here have SMM, smoldering myeloma, indolent myeloma. However, you can see that we have again this red dotted red group here that is newly now considered active myeloma and require treatment, more than 80% of them because they develop myeloma within 2 years. But we still have a series of patients, some of them more like MGUS, and possibly some of them that do and will develop myeloma. And therefore, should we treat this patient, and do we have enough experience, enough markers, justification to treat these patients? So first of all, based on the criteria that the two teams, I would say, in the world, the team of the Mayo Clinic, Professor Rajkumar, Shaji Kumar, Professor Kyle, historically have looked into, but also the Spanish, the PETEMA group, they have long time ago looked at various criteria, different, by the way, from one to the other groups, and clearly identified patients that have some sort of high-risk smoldering myeloma, will develop within their lifetime myeloma, approximately 50% chance at 2 years, but that means also 50% chance beyond 2 years. And this is why we have questioned whether an early treatment could help this patient, prevent the psychological difficulties of living with the cancer without treatment, and potentially also the difficulties for the physician and the patients to wait for an end organ damage to arise and then to start the treatment, which everyone would agree is probably not something good for the patients. So the problem we have is that here, I've listed for you a series of markers that the Spanish and Mayo Clinic has used long time ago. Since then, a greater number of markers, of clinical and biomarkers, have been identified to try to pinpoint this high-risk subpopulation of the multiple myeloma, indolent multiple myeloma, since we've said it's an heterogeneous group. I'm not going to go through that list. Some of them are pretty obvious. Some of them are available in routine life. Some of them are not available in certain parts of certain countries. And some of them are not even ready for prime time. Bob Kyle, Professor Robert Kyle, has said once that probably the best marker in smoldering myeloma was just to watch and wait the patient carefully. Some of the patient once a year, some of the patient twice a year, but some of the patients every 2 months. And only the change over time will probably be the best marker to identify the patient that will progress, and when they progress, and only when they progress, would require early treatment decision. And so potentially the last biomarker, which I've listed here, which is actually is not a biomarker, it's just a basic routine life, good sense of what a physician should be, recognizing that all the markers potentially could be a good marker. But are we going to really look at all these markers to decide for the treatment? So as an example to the fact that I believe we should not yet start the treatment because the markers to identify the patient that should start a treatment are not yet ready for prime time in real life. This is an example. It's actually two examples. I have looked into clinicaltrial.gov, two studies coming from the US, since Professor Rajkumar is coming from the US, one from the ECOG, possibly actually Professor Rajkumar participated, likely he participated to that study, and one from Dana-Farber Cancer Institute, and two institutions pretty known for their expertise in myeloma. And what you can see here is that the two clinical trials have been run in the group of smoldering myeloma, supposedly with high-risk profile. And you can see that if some markers are redundant, a good number of the markers are actually absolutely not redundant. I'm not talking here about PET-CT of MRI. The definition of genomic is actually pretty much the same, but the circulating plasma cells on the right part are not appearing on the left part. And that speaks to the fact that clearly we would agree all these markers are interesting, potentially good markers. However, clearly there is no consensus. And I think that if there is no consensus, we cannot write recommendation saying we should treat patients, although we have no consensus on what are the markers to treat the patients. So I do agree, and I think we do agree, Professor Rajkumar and I, that indolent myeloma is an heterogeneous group. Some have more like an MGUS profile, some are more like high-risk myeloma, with active myeloma soon arising. As much as soon is difficult to define. So there is an ongoing, hopefully soon published, very important international effort that has been guided by the Mayo Clinic on behalf of the International Myeloma Working Group, which is called Mayo 2018, also called 2220, or IMWG 2019. It has taken time. It took time to develop these markers and agree on the most appropriate markers. The first definition, Mayo 2018, is up there, an addition to the genomic profile of the patients. Is down there and is called the IMWG 2019. Likely the most updated recommendation and the most updated consensus will include the upper part and the below part. So if I'm trying to focus on the upper part, the idea would that you would have a list of markers like the SPEP, M-spike, the involved to uninvolved ratio from free light chain, and the bone marrow plasma cells. And if you hit these different cutoffs, you would be separated within low, intermediate, and high. None of the markers, you are below, you are low risk. One, you would be intermediate, and 2 or 3, you would be high risk. Now, even if you look at high risk, as I've said, you reach a 46% risk of developing myeloma within 2 years, which means that if you treat a patient with high-risk smoldering myeloma, you have 50% chance that really the patient will benefit from the treatment. But you also have 50% chance that the patient, despite having a supposedly high-risk profile would have developed within 5 or 10 years myeloma, and if the patient end up with a thromboembolic event because of the treatment, intensive care unique resuscitation because of a severe septic shock syndrome or a severe handicapping neuropathy, possibly this patient would have developed myeloma within 5 or 10 years, and you would have treated the patients likely too early on. If you combine these markers, if you combine these markers to the genomic, you probably can better define patients with low, intermediate, and high risk. And why am I saying that? It's because if you combine the above markers with the below genomic-based markers, you can see that in the group with high risk now, you have a 63% risk to truly develop active myeloma within 2 years and truly need a treatment within 2 years. And therefore, to treat these patients potentially earlier on at smoldering stage would be of interest, because you would save the patient for potential myeloma-defining events and organ dysfunction. So do we have a consensus on the criteria? We might. However, it's still unpublished. So the next question is, why do you want to treat this patient? These patients are asymptomatic. These patients are obviously indolent. These patients might develop myeloma, potentially within 2 years, but again, they are doing good at the time you see the patients. So what are you saying to a patient that would say, doctor, I don't want to be treated? Why would you want me to be treated? I can wait. So why would you treat smoldering myeloma earlier on? This is based on the principle that potentially you can cure these patients. But is that true with myeloma? Yes, a colon polyp, if you exercise the polyp before it becomes cancerous, or from the polyp spread to the margin or to the membrane, yes, you will cure the patient from the risk of colon cancer. But is that true with myeloma? Well, there are a series of ongoing studies, and I will go through that to try to demonstrate that I don't think in myeloma we have proved yet that you can cure myeloma with an early approach treatment-based. However, I do agree that there has been a series of attempts that deserve our attention, deserve our expertise, and deserve that we look into in details, because we can learn things from these various attempts in clinical trials. So the first one, the historical one, is Kiredex study performed by the PTMA, the Spanish group, published by Professor Mateos in the New England Medicine Now, which has been the first to truly address the question of should we treat or can we treat, and what is the benefit of early treatment for patients with high-risk smoldering. And so in that study, they gave the patient Lendex versus simple observation. You can see that the benefit of treatment is pretty impressive. And you can also see and appreciate that the patients that had no treatment developed myeloma within approximately 2 years, which truly speaks to the fact that the Spanish population has really looked into patients with high-risk smoldering myeloma. However, there is a limitation to that study that probably everyone knows, which is that it is not completely clear, and most would say it's unclear, whether some of these patients in the observation group didn't have already the criteria for treatment. The new criteria for treatment, the bone marrow involvement above 60, greater or equal 60%, the serum filtration ratio greater 100, and or the focal lesions, more than 2 focal lesions on MRI spine and pelvis. Because back then, when that study was conducted, these new criteria were not clearly identified yet. So as much as that study has pioneered the question, is a pioneer study for the question of should we treat these patients, I don't think we can use that study truly to say, well, it's obvious better than that study, and there is no limitations, no bias in that study to completely say that high-risk myeloma should be treated. So, however, there has been a more recent study that has probably better defined high-risk smoldering with the more recent updated criteria for high-risk smoldering. That study is online, available to you, I believe, in JCO. And that study, published by Sagar-Lonial, run with the ECOG, clearly has showed a benefit of Revlimid single agent versus observation. You can see the progression-free survival of the two groups, lenalidomide, largely on top compared to observation. And you can see the cumulative incidence risk of developing myeloma, active myeloma, potentially with organ malfunction. I agree to that. Here, lenalidomide versus observation. Well, however, as a scientist, I see two things here which I like to share with you. Number one, as you can see here, the observation group clearly, I shouldn't say relapse, clearly develop active myeloma more often. However, even the Revlimid developed myeloma. So even the Revlimid approach did not cure at all myeloma, and in a certain extent lowered the development of active myeloma, but still active myeloma developed. And the other point I would like to share with you is that this curve here clearly is below lenalidomide, but it is not a deadly curve. It is not a curve where 100% of the patient would die within 6 months. So that does not justify entirely, I believe, the reason to treat myeloma immediately. And what I would like to say on top of that is that overall survival was not different across the two groups. So you could say, well, the median follow-up is too short. Maybe overall survival will separate later on, and in that type of myeloma, we would expect a late separation of the curves. So the argument that the curves haven't separated yet is a bit too easy, and I would agree to that. However, at least that says, because we have a 36 months here sort of follow-up, so that says at least that a certain number of patients may maybe not need a smoldering high-risk treatment, wait for active myeloma and get treated when they have active myeloma and gain months, years of quality of life not being treated. And in the end, so far, there is no difference in terms of overall survival. The next question, which is key and a key element to why we should not treat, or at least not yet in real life, treat myeloma with indolent profile or smoldering profile, is that what treatment are you going to give your patients? Even if we would to agree with Professor Rajkumar that a treatment should be given to certain number of these patients and possibly the high-risk smoldering, but what are you going to give? Revlimid dexamethasone, daratumumab? But why don't you give isatuximab? And by the way, why don't you give the Spanish approach, which should be, if to treat myeloma, just treat myeloma, bortezomib, thalidomide, dexamethasone, transplant if transplant eligible, and then consolidation and maintenance. Or here, an attempt to reach cure, which is carfilzomib, Revlimid, dexamethasone, transplant, carfilzomib, Revlimid, dexamethasone, and then Revlimid, dexamethasone as maintenance. So I think one of the reasons we should not treat is not just because we don't have identified perfectly the biomarkers to do so, but so because we are not 100% sure that all the high risk need a treatment right now and should not wait when they become active to be treated. As we've seen, the overall survival curve has not separated yet in the ECOG study. But it's also because you don't have any idea of how you should treat these patients. Should we control the immune niche, or should we try to seek for cure with the maximum debulking, reaching MD minimal disease, and potentially being able to say to the patients, well, with a negative MD at 10 to minus 5 and 10 to minus 6, this early treatment really benefited to you. Trying to kind of wrap up my talk in this debate, I'd like to say that there are two very remarkable manuscript papers, available online that were educational to the ASCO meeting this year. one from Dr. Lomas and Dr. Gobrial, and one from Dr. Joseph and Dr. Lonial. I encourage you to go read these papers because then I think that will give you the entire idea about why is this topic difficult, and why do we debate with Professor Rajkumar about this. And again, everything I spoke about is listed for you in more details in these two manuscripts. If I may, as a conclusion, I'd like to wrap up my talk with a couple of slides saying that even if we decide to treat this certain number of smoldering myeloma patients and not to speak about the high risk, even if we would to agree on that, treating myeloma has always been, for certain number of patients, very, very detrimental. First of all, we now, and this is a beautiful paper published by Jonathan Keats now years ago, but we see this in our real life constantly, patients who have a clonal selection. We know myeloma has constantly a clonal longitudinal shift, moves, evolution among the different clones. However, sometimes a very poor clone takes over, and a very poor clones develop, we call it clonal selection, and this clone is very rapidly developing mechanism of resistance, and the patient often die because of this development. If you treat a smoldering myeloma, high risk, early on, because you want to protect the patient from the risk of developing a poor myeloma or organ dysfunction and organ damage disease because of myeloma, you may just create a monster if you unfortunately have a clonal selection. And this seems to happen more often if you have an underlying high risk, ultra high risk genomic profile. But the high risk genomic profile, smoldering myeloma population, is likely going to be the population you will treat early on, if you decide so. And therefore, you might just create a monster for some of these patients, out of the evolution and clonal selection. Furthermore, if you read the paper from Professor Lonial, which again, I have to say it's one of the best papers since early Jan 2020 I have read, and I think everything that is outlined in this paper is excellent. And my understanding is that Dr. Lonial would possibly consider that a treatment would be needed, or more likely needed, and recommend that possibly we would use an immunomodulation or an immunotherapy to control the immune compartment, the immune component of the tumoral niche. And I would agree to that. But I'd like to remind everyone that if you give Revlimid, lenalidomide, whatever single agent monotherapy or in combination to patients, at some point, even smoldering myeloma will end up being refractory to lenalidomide. And as far as we stand today, patients with refractory lenalidomide myeloma disease have immediately acquired some sort of high-risk functional profile. And you can see here, for example, I picked Castor, and apologize for I'm convinced daratumumab is an amazing drug for myeloma, but I picked Castor because daratumumab, Velcade, dexamethasone being a very good treatment of myeloma. In the right curve here, the kind of greenish panel I've attached on the right part of my slide, you can see that in len refractory patients, as much as daratumumab, Velcade, dexamethasone with a daratumumab maintenance approach is an amazing treatment to relapse refractory myeloma, the PFS of these patients once given to len refractory was absolutely terrible. And therefore, I fear that we might treat smoldering myeloma high risk, whatever the definition, and this patient will benefit. But at some point, they will become refractory. And what then? What will then happen? We will have prolonged the smoldering sort of profile of the patients, but are we so convinced that we will ultimately prolong the overall survival if, once refractory to lenalidomide, the patients are becoming high risk, functional high risk, because very difficult to treat thereafter? And you can replace Revlimid by daratumumab, it's about the same story. If you look at data, for example, from the Mammoth study, where patients who had been refractory to daratumumab truly had hard time being rescued thereafter with whatever treatment most of the country and most of the European country have access these days. So I'd like to wrap up my talk saying, first of all, I want to thank you for your interest into looking into this recording. I hope my elements, my arguments would have pleased Dr. Rajkumar and help him build in his arguments and for the sake of the debate. I do think we are going to treat a small population of smoldering myeloma in the future because of high risk. I'm still not convinced, and I'm actually convinced that we should not do that in real life. We should only do that in the context of a clinical trial. And with this, I thank you very much for your attention.